Yeah. Einass, you can start.
Yes, ma'am. Today's topic is on wound healing and tissue repair. Uh, a wound basically represents a disruption in the normal structure or the continuity of the skin, and it also affects the functioning of the skin with or without affecting the underlying soft tissue structures, which could be the underlying muscle, bone, nerve, following any injury. And there are various mechanisms by which injury can occur, which has both acute and chronic etiologies. Further, wound can also be classified into acute wounds and chronic wounds. The acute wounds usually have a mechanism of injury which results in the disruption of skin integrity because of some form of trauma. And this acute traumatic disruption can be because of any blunt injury or because of some penetrating mechanism. And in addition, there could also be because of abrasions, crush injury, thermal injury, or even animal bites. And Surgical wounds are a type of acute wounds, but these are a controlled form of acute wound which are created by us. And yeah, these also come as a part of an acute wound. Chronic wounds develop over a period of time, either from an acute traumatic or surgical skin injuries, or it could be as a result of a breakdown from a previously intact skin. Mainly patients who have an impaired pain sensation, who are and are vulnerable to uh, acute and chronic repetitive injuries. Usually, these injuries might go unnoticed and therefore manifest into chronic wound injury. And these specifically include patients who are suffering from diabetes, peripheral arterial disease, or any neurological disease, because of which the patients are immobilized for a longer period of time, resulting in pressure induced injury. Going to the phases of wound healing. The phases of wound healing primarily include four phases, which the first being hemostasis, followed by inflammation, proliferation, and then the final phase being remodeling. The usually the when in case of hemostasis and inflammation, hemostasis usually precedes inflammation, and it is also considered to be an initiating factor for inflammation, which will uh, following hemostasis, there will be a release of chemotactic factors over the wound site. Therefore, it is considered to be an initiating factor. Uh, in When we are talking about the hemostasis phase, usually the injury to the blood vessel will result in an local vasoconstriction followed by vasodilation, and this will result in an increase in vascular permeability. And therefore, your erythrocytes and platelets will adhere to this damaged capillary endothelium and result in the plugging of the capillary. And this will help in the cessation of the hemorrhage process. The platelets will adhere to the endothelium, which is mediated by the glycoprotein receptors, that is GP23A, and thereby the platelets will adhere to the endothelium. Uh, Furthermore, platelet activation, this is followed by platelet activation, which is occurring because of the exposure of the platelets to the type 4 and type 5 collagen, which are present in the damaged endothelium. And this will further cause platelet aggregation. And finally, the platelets are also, after the platelet activation, there will be release of factors from two sources. There will be alpha granules and dense bodies. The alpha granules will be secreting your platelet-derived growth factor, or TGF beta, or insulin-like growth factor. And so the dense bodies are responsible for secretion of the vasoactive amines, which could be serotonin, which is responsible for further vasodilation and vascular permeability increase. And after this, once the platelets become activated, there will be the uh, the membrane phospholipid factor 5 will allow basically there will be whenever an injury happens, there is an extrinsic pathway mechanism which gets activated. This will include your factor 7A, your factor 9A, and factor 10 as well. So all of these factors will further help in activation of the platelets, and this will potentiate thrombin production. Thrombin itself further activates platelets, and it will help in the catalysis of conversion of fibrinogen to fibrin. And herein, fibrin will trap the RBCs and help in the formation of the clot. So here we can see, like, we have the inflammatory phase, the proliferative phase, and the maturation phase. Basically, all of these phases are sort of coinciding with each other. Going to the inflammatory phase, the inflammatory phase there are two. The first, you will have infiltration by the nucleosides, that is the neutrophils, that will be infiltrating the cells. That is seen at the peak in the first 24 to 48 hours. And the main primary role of these neutrophils is phagocytosis of bacteria and the tissue debris which is present. And they are also a major source of cytokine release during inflammation. This has a significant influence on further angiogenesis and collagen synthesis. Then, furthermore, they will also release proteases like collagenase, which will help in matrix and ground substance degradation, which is a part of the early phase of wound healing. Then the second cells which will come into play are the macrophages, which are again important for the successful healing process. And this will happen in the next 48 to 96 hours post-injury. And they will again, like neutrophils, help in debridement via phagocytosis and help in they will also help in microbial degradation by free radical production. Other than these macrophages, there are T lymphocytes, which are the third cells which are usually a part of the inflammatory process, and they will peak about 1 week post injury, and they bridge the transition from the inflammatory phase to the proliferative phase. In addition, we also have macrophages having the following functions, which includes angiogenesis, cell recruitment and activation, which includes activation of growth factors and cytokines, the matrix synthesis regulation, wound debridement, and the phagocytosis and antimicrobial function. So these were the two phases. First was the hemostasis phase, wherein we had the platelets coming into play and forming the fibrin clot. And the second phase, which was the inflammatory phase, which involved neutrophils, macrophages, and the T lymphocytes, causing various inflammatory mechanisms and release of cytokines. The other two phases, going to the next two phases, the proliferation phase and the remodeling phase. Your proliferation phase is it roughly spans for about like from day 4 to day 12. And in this phase is mainly responsible for establishing your tissue continuity. The fibroblasts and endothelial cells are the last cells which will be coming into play. And the strongest chemotactic factor for the fibroblasts being platelet-derived growth factor. Upon entering, the fibroblasts will proliferate, they will activate, and then their primary function is that of matrix synthesis and remodeling. And this activation is again mediated by cytokine and growth factors, which were released from the macrophages. Then further, the endothelial cells will also proliferate extensively during this phase of healing. And these cells participate in the formation of new capillaries, that is, they help in the process of angiogenesis. And the third phase, the last phase, is that of remodeling, that is maturation and remodeling, that begins, it starts itself during the fibroplasia phase, wherein the fibroblasts are at the peak. And herein, collagen is broken down by MMPs, and basically there is a net balance which is created between collagenolysis and collagen synthesis. This is followed by deposition of matrix such that there is fibronectin and collagen type 3, which is present in the early matrix scaffolding. And after that, there will be a plateau phase, after which there will be formation of various cross-linking mechanisms. And fibrillin, the glycoprotein which is secreted by fibroblasts, will come into play, and it will also help in the formation of your elastin fibers.
Einass,
These
one
are the...
second. Ravi
Yes,
Shankar
ma'am.
sir is here. Sir, good evening, sir.
Good evening, sir.
Good evening. Sit and listen.
Yeah. You have told Sanya and this one to actively moderate up. I will be. Yeah. Yes, Sanya, you can ask questions or.
Yes, she's finishing this thing, I think, sir. All the
Yeah.
phases.
Let her finish. Yeah.
Yes, sir.
Yes. And the last phase is the epithelialization phase, wherein the basically your tissue integrity is being reestablished and also being restored. And this process is primarily characterized by proliferation and migration of the epithelial cells adjacent to the wound. The process will begin, it begins at the first day itself of injury, and then you see that there is a thickening of the epidermis at the wound edges. The marginal basal cells at the edge of the wound lose their firm attachment to the underlying dermis, enlarge, and they will begin to migrate across the matrix. Further, there will be fixed basal cells in a zone near the cut edge, and they will again go rapid mitotic division, and these cells will migrate by moving over one another until the defect is completed. Once the defect is completed, these epithelial cells will become more columnar in shape, and the layering of the epithelium is re-established, and eventually the surface layer will keratinize. So de-epithelialization is completed in less than 48 hours in case of approximated inside wounds, but it depending on the size of the wound, larger wounds might take a significantly longer time in comparison to smaller wounds. I'll go ahead, ma'am.
Sir, Ravi Shankar sir is asking a question. How do you explain the early post-operative adhesions and obstruction based on whatever the phases of wound healing you've described?
Ma'am, mainly because of the proliferative phase, which is occurring at day 4 to day 12, wherein your fibroblasts are extensively active. That could be a cause for the adhesions which are seen, sir.
Sir, hello?
Hello.
Sir, is whatever she said is...
No, I just asked the question.
Yes, sir.
So, for example, if all these phases are all defined and they go along a structure, for example, the latest, this patient who had ovarian cystectomy, developed adhesion obstruction. I think I don't know how soon was it, but it was probably 4 or 5 days old, I think, isn't it?
Yes, sir. Post-op day
Yes,
6,
sir.
we took her up for re-exploration, sir.
So how do you explain adhesions forming so early and causing obstruction?
Sir, was it due to METs, this thing, or surface METs producing adhesions, or was it a new this thing, band?
No, sir. Looked like bands and interbowel adhesions only.
But how can it form so early, within 4 or 5 days, bands?
Uh,
It's POD 10, sir.
10.
POD
POD 10, sir. Sorry.
But even then, that is very early.
Early.
For a thick fibrotic band to form, it will at least take 2-3 weeks for at least.
Yes, sir.
Sir, and intraoperatively, there weren't any thick fibrotic bands per se, sir. They were just interbowel flimsy adhesions, which were causing the obstruction.
Which what was it? It was flimsy adhesion.
Not fibrotic bands, sir. Bands were not there. Ma'am,
Okay.
how do you describe them?
Interbowel adhesions only, sir, which with finger dissection only, sir, could separate. But at one point, that interbowel adhesion was causing obstruction, sir. Look like that.
But how can it cause that if it is so flimsy? Usually interbowel adhesions,
Yes,
so many
sir.
times you people have seen interbowel adhesions, chronic will be
Adhesions.
there.
Yes,
But
sir. Probably this interbowel adhesions associated with paralytic ileus.
okay.
That
So
was
after
like
release of that, was the obstruction relieved?
yes, sir. Now the patient doesn't have any distension and bowel sounds are also heard now.
Okay. Don't know. Sir, how to explain that? I don't know.
That is what I think all of you guys need to look into it. But my hunch is some of the situations may promote, as you said, the proliferative phase, the fibroblast
Fibroblast, yeah.
proliferation may happen in an accelerated fashion. I think infection may be one of the things, and then you will have to look at other causes for that. Is there
Yeah,
any
that leak, if there is leak or something that itself can cause, and abscess pus can cause probably dense adhesions. Quick, it will probably accelerate the adhesions.
accelerated proliferation of fibroblasts due to maybe infection, may, as Niranjan said, malignancy. There is underlying malignancy that may cause that. So we'll have to look into that specific reason why.
Yes, sir. I think we have to go through articles in which we can find about this early post-op adhesions, how they are forming.
No, I
Because
think that's homework for all of you.
yes, sir, yes.
Go through articles and see early post-operative adhesion and obstruction, and see what is there any postulated cause for that.
Yes, sir, yes. Anyone else? Any questions in this four phases of wound healing?
No, ma'am.
Okay.
Einass,
If nobody,
I want to ask you
Yes,
a question. Tell me the predominant, just summarize quickly about the predominant cells that are involved in each phases of these wound healing.
Ma'am, so
very good question.
in each phase, ma'am, so during
Yeah.
the phase of hemostasis, you have platelets and erythrocytes.
Yeah.
Then after that, you get your neutrophils
Yes.
in the initial 24 to 48 hours, followed by macrophages. Then after that, T lymphocytes, which will occur about 1 week post-injury. Then in
Hmm.
your proliferative phase, you have the fibroblasts.
Yeah.
And also the endothelial cells, which will help in formation of new capillaries. And ma'am, finally, there'll be the maturation and remodeling phase, wherein your collagen breakdown is
Gotcha.
happening. And yes, and epithelialization, this actually begins from the initial day one only, wherein your epithelial cells are involved in proliferation and basically establishing the external barrier.
Yeah.
And
Okay.
Einass,
one more cause I forgot to mention is bleeding. Blood
yeah,
can produce dense adhesions and
yeah.
rapid adhesions.
Einass,
Cause their bleeding.
Einass,
Yes, sir.
are you going to give us a timeline of this wound healing process?
Sir, I like initially, like I had said, sir, that you hemostasis and usually there's hemostasis first, followed by inflammation, and
Timeline. I
so
know.
Like 24 hours, 48 hours, when is it? That is what sir is asking.
yeah, hemostasis is in the initial 24 hours, sir. Before 24 hours, then you have your the cellular infiltration again, which is uh, from ranging from 24 to like the day 1 to day 4. Then the proliferation phase is from day 4 to day 12, sir. And after that, you have the maturation and remodeling phase, this can go on for about 6 to 12 months, sir. And
Okay.
epithelialization, which is usually around 48 hours.
Now, what is the final tensile strength of the tissues that have healed compared to the original tensile strength? How much does that reach?
So I'm not sure about that, sir.
Anyone?
80%,
is
sir.
80%.
80%, sir.
80 to 85%. Now, Ainas,
Yes, sir.
what stops the wound healing process? Because it can keep on going, no? It can keep on going, and obviously that brings you to the next question of hypertrophic scars and keloids, but that you can address later. But what actually stops the wound healing process? When does the body know, yes, I have now healed completely, I can stop it now?
So it like I am not sure, sir, but then in particularly, sir, like you have the fibroblast factors and the platelet derived growth factors, all of these cytokines which will help in analyzing when it is complete, sir.
I think what you should do is to see if you have read this wound healing process in your surgical textbooks. It may not give you all the information. Go to physiology textbooks and pathology textbooks and then read. I think there you will get the molecular level of wound healing, and probably they will give you molecular level of when the wound healing stops. I maybe I may be wrong. Then when I Robbins, I don't know. Have you heard of textbook called Robbins Pathology?
Yes,
yes,
sir.
sir.
Yeah.
Yes, sir.
So Robbins had given that because I think the understanding of wound healing obviously has accelerated, exponentially. But at that time, they had said that there is receptors. This one called shallones, CHALONES. These are growth regulating factors which are present in all the tissues, and when the healing is almost complete, the shallows prevent further healing process, and it will regulate the growth. So in patients who have tendency for keloids and hypertrophic scar, I think there is deficiency of these shallows. Whether that is still the case or there is more understanding and those shallows have been replaced by more definitive factors, I'm not sure. Just check on that.
Yes, sir.
So all of you have to look into that. So two homeworks already. I think you should note it down. It is not just for for us to say something and then you go away and not bother about it. It has to be followed up.
Yes, sir.
Okay, right. Carry on.
Yes, sir. The in the types of wound healing, it can be categorized into primary, secondary, and tertiary wound healing. And here, your primary wound healing is also known as the healing by first intention. This occurs when there is a direct approximation of the wound edge, and basically this is normal healing, and it is associated with minimal scar in the presence of no adverse effects. The secondary healing is wherein the wound is left open, and it heals by granulation followed by contraction and reepithelialization. This is characterized by increased inflammation and proliferation and is associated with a poor scar. And the tertiary wound healing is the delayed healing, wherein the wound is initially left open and the edges are approximated later on when the healing conditions are considered to be favorable. So the representation of first healing by first intention, second intention, and the last image showing healing by third intention. Then further going to the factors affecting wound healing, these can be categorized into systemic factors and local factors, wherein the systemic factors include age. Advancing age is considered to be associated with delayed or impaired wound healing. And furthermore, even nutritional status, that is poor nutritional intake, wherein patients are malnourished or susceptible to more altered aspect, more alterations in wound healing, and thereby they are associated with more wound infections and wound adhesions. uh, Immunosuppression is also considered to be one criteria which affects wound healing, basically because they inhibit the inflammatory phase of wound healing, thereby affecting the angiogenesis phase, the neutrophil and macrophages migration, the fibroblast proliferation, and this is how they contribute in inhibiting epithelialization and contraction as well, resulting in an increased rate of wound infection. Uh, Smoking and metabolic disorders like diabetes mellitus, cardiovascular disease, uh, all of these are associated with poor, they adversely affect the wound healing process, in which uncontrolled DM results in inflammation, results in reduced inflammation, angiogenesis, and again collagen synthesis. And in addition, the diabetes is also associated with large and small vessel disease. This contributes to local hypoxia, further contributing to impaired wound healing.
How does smoking
Then,
affect Einass? What is the pathophysiology? Smoke.
sir, in smoking, basically, sir, nicotine is the responsible factor, sir. Uh, that is what is affecting the wound healing, sir.
No. It may be, but what
That is
actually
not the cause. Anybody else?
smoking affects it in many ways.
It affects the collagen also, sir.
Okay, what that is one. What else?
Decrease vascularity, vasodilation action of
Not
what
Yeah,
Einass
so
has
there
vasodilation.
are
mentioned.
multiple factors. One
Not
is
vasodilation.
reduced blood flow,
Vasoconstriction.
which vasoconstriction,
Vasoconstriction.
which it damages the blood vessels, and then hypoxia also decreased oxygenation,
Tissue hypoxia, tissue hypoperfusion, and then
and
also
it
an effect on the collagen synthesis.
and also vitamin C. It will lower the vitamin C levels. And next comes the nicotine, carbon monoxide, and hydrogen cyanide, which will be there, which will impair wound healing.
Nikita, tell us about why diabetes causes impaired wound healing.
Sir, hy- hyperglycemia also results in
Again, multiple factors. It is not single factor in diabetes.
It is easy for us to say diabetes, but if I think you should know the mechanism. Praveen,
Sir, in diabetic patients causes reduced inflammation and angiogenesis, sir, and decreased collagen synthesis, and there is local hypoxemia, sir.
why hypoxemia?
No, main thing is hyperglycemia. What does it cause in diabetes? Along with all that, whatever you mentioned.
infection also, it increases, sir, the growth of other organs.
No, it slows down the circulation, causes leading to stiffer blood vessels and reduces the oxygenation. That is one.
Hyperperfusion.
Yeah, hypoperfusion, and then neuropathy. There are multiple factors. You should be knowing this in detail.
I think all of you need to actually. I keep on telling you guys, you need to go into certain details because these are topics which are studied maybe once in 2 or 3 years. So when if a topic like this comes up,
This
you
is
need
superficial. Whatever you people are telling, it's very superficial. MBBS level.
yeah, you should He should have gone into, the pathology articles, find out what actually diabetes does, what happens in wound healing, what happens with diabetes and wound healing. I think, it is because the two important things that we deal with, the three actually, is age, nutrition, diabetes, and smoking. So these are the four things which immunosuppression happens that not that frequently. So you should know about smoking, diabetes. See, Niranjan rattled out everything, taka taka taka. I think you should be doing that. Ainas, you have also not explained why diabetes, what happens in diabetes.
So, that is what I'd read, sir. Angiogenesis and collagen synthesis, and in addition, it is associated with like where it causes a vascular disease like vasculopathy, sir, so which causes hypoxemia, and thereby it affects the capillary ingrowth and proliferation. And in addition, it is also associated with obesity and insulin resistance, sir. So in some patients, which will
Yes.
cause impaired wound healing.
So that word I was looking for, insulin resistance. That happens. Insulin resistance is there in the post-operative phase. In diabetics, that is more accentuated. So that is another
Yes, sir.
important factor in delaying the wound healing.
And
Okay,
also
carry on.
reduced production of collagen as well as reduced growth factor production happens in diabetes. And one more important factor is nerve damage, neuropathy. Okay, carry on.
Yes, sir. The other factors being the local factors wherein edema, wherein there's
Anas, one
accumulation.
second. Sir
Yes.
Ramakrishna sir has joined. Good evening, sir.
Good evening, sir. Good evening, Ramakrishna, sir.
Oh, good evening. Good evening. Sorry, I joined late. My Zoom app was giving little trouble.
No problem, sir.
Okay, thank you.
Good evening, Ramakrishna.
Oh, good evening, sir.
Carry on, ma.
Yes, sir. So edema, wherein it will cause, regardless of the etiology, there is accumulation of interstitial fluid, which will reduce the integrity of the skin, making it more prone to injury. And in addition, the increased interstitial pressure will also impair the diffusion process and cellular function, which is required for the normal normal healing process. Then we have also have like ischemia and low oxygen tension. Where low oxygen tension has extreme adverse effect. Fibroplasia initially may be stimulated by a hypoxic wound environment, but it will get significantly impaired in case of local hypoxia. Then collagen synthesis also requires oxygen as a cofactor. And again, in case of low oxygen tension causing hypoxia and hypoperfusion, this will be affected. And the major factors which will affect and result in low oxygen tension includes your arterial insufficiency, or it could be because of systemic reasons like a low volume, or in patients who have cardiac failure. And finally, there's immobilization, wherein there is like immobilization in terms of patients who have like prolonged spinal cord disease, or they were at an increased risk of developing chronic wounds, and they will occur in the most prominent bony prominence, which could be the sacrum, knee, or heels. And the last factor being radiation. So radiation is basically wherein there are functional changes which occur in the non-cancerous tissue, and as have a as a direct result of these radiations, and this may result in cell death and apoptosis, causing tissue necrosis further. And
Wait. I think
Yes, sir.
Immobilization, you are talking about, pressure source and wounds happening. So that is cause of wounds happening. But you are talking about immobilization causing delayed wound healing. So how is that related?
No, I meant like immobilization is a like it will if there is prolonged immobilization and if there is an wound, then it will go into a chronic state, sir, because of low
Why?
perfusion, sir.
Correct. So there is less mobility, less tissue perfusion, and so that is why there is and less tissue oxygenation, and so delayed heal. So pressure source has got nothing to do with immobilization causing delayed wound healing. They are two different things. Now tell me about edema. Why is edema, and what are the factors in edema? And you said about low oxygen tension. Low oxygen tension not only happens in cardiac illness, but it also happens in pulmonary diseases, in patients with chronic airway disease, patients with bronchiectasis and all that, where the tissue oxygen exchange mechanisms are impaired, and hence there is low tissue oxygenation. So you forgot to mention about the pulmonary diseases. Cardiac diseases, agreed, but pulmonary diseases are also equally important. Now tell us about the edema. What are the factors which cause edema?
So, if there is increased capillary pressure, sir,
Due to
then
what?
uh, so like it could be because of so the like the basically the sphincter mechanism, sort of like the arterial
See, it's
so
very simple.
leak as well. Yes, sir.
Very simple thing. Everybody just glosses over edema. Nikita, can you tell us the mechanism of edema?
So two causes, sir: cardiac causes and renal causes.
Correct. And then what
Uh,
else? Cardiac, renal, and then one more.
nutritional causes, sir. Nutritional causes like
Nutritional,
decreased
and
protein,
then
hypoproteinemia.
Liver,
Infective causes, sir.
liver
Liver disease.
disease, infection. And as a natural process of wound healing, initially there will be edema in every wound healing. But because of the increased tissue perfusion due to increased vascularization, the fluid gets absorbed. And if there is good amount of protein, the tissue colloid oncotic pressure will drive the fluid back into the extracellular space, and hence the the fluid that is flooding the healing process will get absorbed, because the plasma and serum will obviously they are all fluids only, so the fluid will get absorbed. So when patients who have all the factors that you just cardiac illness, renal diseases, liver disease, hypoproteinemia, in such patients and other things that we cause, what is that doctors cause which can cause edema? I keep on drumming this to you guys. Ainas, or let us go to Nitya. What is that we do as doctors which causes edema?
Sir, immobility post surgery.
Okay, immobility,
No,
but we don't
during surgery, what will you cause? Which causes
we,
more edema?
we don't cause immobility.
During
What
surgery,
was
due to
Excessive
uh,
tissue handling, sir.
Correct.
tissue handling and
So
dissection.
tissue hand?
improper, yeah.
Lot of diathermy, burning, and tissue handling. Agreed. And what else? What does anesthetists do? They will be reading
IV
numbers.
fluids.
Overhydration.
Overload of fluid.
Overhydration.
Correct.
Yeah.
See,
So increased
obligatory,
IV fluid, obligatory, and sir is
under
mentioning. Yeah.
obligatory underhydration is the this one. Now you should not give more fluid. What is called as goal directed therapy. You should, if you can't monitor, err on the side of giving less fluids than more fluids. If you have patients who have cardiac and other problems where you need to monitor. You have to have a central line, or better still, you have a esophageal, transesophageal Doppler, and monitor the amount of fluids that is required according to the cardiac output, systemic vascular resistance, and then give fluids accordingly. So that is, all these are factors with edema. So it's very simple to say edema and go get over it. But I think there are so many factors associated with that.
Yeah, Ramakrishna sir has few questions, I think. Sir, you will ask her?
No, few things she missed, I think. So
Yeah,
you mentioned that the causes of edema, hepatic edema is also one of the known factor.
Yeah.
And
so any
in systemic,
connective tissue disorders. Yeah. Einass, you missed that. What are the connective tissue disorders which will impair wound healing?
So there is Ehlers-Danlos syndrome which can affect wound healing, sir. Then even Marfan syndrome is associated with impaired healing. Osteogenesis imperfecta is also one condition. All of these are associated diseases which can have impaired wound healing.
Yeah.
Some enzyme is there, like MMP, matrix metalloproteinases.
Proteinases. Yeah.
If it is in excess, it causes recurrent hernia. It's well documented. So that's also one type of connective tissue healing disorders. And immobilization, you are telling always it hinders the healing. Actually, we encourage immobilization sometimes to encourage healing. Is it so? Is it not? Because
Yes,
when fracture occurs, we immobilize the fracture site. And when cellulitis is there, we advise rest many times with elevation. That helps in healing.
yes, sir.
So immobilization may not be always a negative point there.
Especially when it is in a joint area and all those things, you immobilize. That is what sir is mentioning. So it will,
Yes, yes, sir.
yeah. Okay, go on.
Going to aberrant wound healing, that is keloid and hypertrophic scar. So basically, hypertrophic scars and keloids are fibroproliferative conditions which will result because of aberrant wound healing in a predisposed individual, which could be because following trauma, because of inflammation, surgery, or because of burns as well. And the first, the etiology and pathogenesis includes dysregulation of the wound healing process. So this herein dysregulation, or this is not a completely understood mechanism, but this will involve dysregulation at one or many of the wound healing phases, which could be the inflammatory phase, proliferative, or remodeling phase, and it could be because of the proliferating fibroblasts, keratinized cells, mast cells, and even the endothelial cells. However, in the development of abnormal scars, vascular endothelium plays a prominent role in comparison to other cells. That endothelial dysfunction leads to vascular hyperpermeability during the inflammatory phase of wound healing, and this will result in a continuous influx into the dermis of the inflammatory cells, and basically this is contributing to an extensive local inflammation and fibrotic activity. Furthermore, at the molecular level, we have the cytokines and growth factors, which have been like the TGF beta vascular endothelial derived growth factor or interleukin 6. All of these are likely to play a role in fibroblast activation, and they also cause an increased production of extracellular matrix. The local tissue factors is mainly the mechanical stretching forces. Herein, the external mechanical force which is placed on a wound or scar are a primary factor which will which are involved in abnormal scar formation, and these stretching forces can both cause and worsen the pathological scar. And herein, keloids have a stronger, they are more prone to these mechanical stretching forces, and therefore they are more prone to occurring at an area of frequent skin stretching and contraction, which could be the anterior chest or the scapula. And moreover, keloids will also the keloids will develop in distinct specific shapes, which will reflect the direction of the stretching forces as well. And in other factors include your cutaneous infection, which could be the folliculitis, which could or acne, and even burn wounds, which can contribute to these forms of scarring. The patient-related factors include genetics, wherein there are some studies which are showing like for example, keloid has a familial pattern, wherein it is showing an autosomal dominant pattern of inheritance, and there are other studies which have showed that HLA polymorphism also has a positive association with keloid formation. And in other factors, there are age, wherein younger age group is associated with an increased risk, and especially in case of keloid formation, with a peak incidence in the second and third decade. And the hormones, for example, increased estrogen levels are also shown to have associated with promoting keloid growth. And diseases like hypertension can also be associated with the development or worsening of keloid and hypertrophic scars. This is mainly because of the damaging effect that the basically hypertension has on the vascular epithelium, vascular endothelium, and this will cause hyperpermeability and cause abnormal proliferation of cells. Herein we have the
Einass,
yes, sir.
have you told the essential difference between keloid and hypertrophic scar?
Sir, I was about to tell that, sir, like in the slide.
And the timeline?
Sir, timeline. Sir, I have not.
And there is another question by Dr. Ramakrishna. It's very relevant. Is there any skin color that is more prone to developing keloids? Very important question.
Sir, it is more in the African and Asian people, sir.
Yes, Afro-Caribbeans
yes,
are more prone to developing keloids. Agreed. What
yes,
is the
sir.
essential difference between? Can anyone? I think Samir. What is the essential difference between keloid and hypertrophic scar, man?
Sir, histologically, the hypertrophic scars will have this well-organized collagen, sir.
No. Essential difference.
Sir, the wound margin, sir, the keloid will grow beyond the wound margin. Well,
Correct. The
yes,
hypertrophic scar is confined to the
confined to
wound,
the yes,
wound per
Original
se,
wound.
and keloid is beyond.
yes.
And when is there a timeline for hypertrophic scar and keloid? Nikita?
Hypertrophic scar usually in the first or second month, sir. Whereas keloid can form in the later duration, like in the next months or years altogether.
Any improvement on that answer? Praveen?
Sir,
Vinod,
usually
is Vinod
hypertrophic
there?
scar for
Praveen.
hypertrophic scar 4 to 6 weeks are post injury, and
That's
keloid
all.
usually.
Is that all? Is there a specific period up to which it can be called hypertrophic scar, beyond which then it
6 months, sir.
double that? I think it up to 1 year, as far as I know. Check on that. Hypertrophic scars definitely will not go beyond 1 year. but keloids can go beyond 1 year also. The time of starting, I think, differs, but keloids can keep progressing.
See, hypertrophic scars initially they become big and then they regress.
Yeah,
Keloids don't. They keep
keloids
growing and they at some point of time they stop, but they will be like they will not become flat. They will never become flat.
will never become flat. Correct.
So minimum time duration is two to up to 2 months. Usually hypertrophic scars, but it can go on for a few months also.
Okay, carry on, ma.
Yes, sir. The characteristic features of keloid and hypertrophic scar, wherein hypertrophic scar is more frequent in comparison to keloid, and the occurrence of keloid is more like there is a more disposition seen in the African population. The site hypertrophic scar can occur anywhere, and it is more frequently associated with contractures, wherein the stretch points, the where the stretch forces are acting, that includes your the upper back, neck, chest, ear. These are the sites which are more prone to developing keloids, and contracture is rare in these cases in them. There is an autosomal dominant pattern which is associated with keloids but not seen in the hypertrophic scar. The keloid will manifest in the form of pain, pruritus, and there can also be hyperesthesia which could be seen. And the classical finding is of that of growth beyond the wound margins. Whereas in hypertrophic scar, you have raised margins, but they are relatively they are respected to the wound. They are restricted to the wound margins, and there may or may not be associated pruritus with it. And histologically, there is thick collagen fibers in random orientation seen in colloid, and the orientation of fibers is parallel in that of the hypertrophic scar. These are some of the characteristics which are seen. The linear hypertrophic scar, which will be red raised, it can be pruritic and confined to the border, and it has a rope-like pattern. The widespread hypertrophic scar, which is a burn scar again, which is widespread, but here again it remains within the borders of burned injury. Minor keloid is focally raised, and it extends beyond the borders and has a genetic component. The typical site for this being the earlobe, and the major keloids are more than 0.5 centimeters, painful pruritic going beyond the normal borders, and these can even result from a minor trauma. Going to the treatment for hypertrophic scar, yeah, we have conservative therapy, the surgical management, and few other methods which are available, other therapies available as well. In conservative therapy, we conservative therapy involves using corticosteroid drugs. Here we can consider even using corticosteroid tapes. Basically, these come in the form of tapes wherein per centimeter square, which can be applied, or these are very potent agents which are used, but there's not a lot of evidence based on this. Intralesional corticosteroid injections are effective in inducing the regression if there are small to moderate sized hypertrophic scars which are involved. Usually we use triamnicolone 2.5 to 10 mg at the site can be given for scar
Triamcinolone
management.
acetate.
Yes, sir. And these can be repeated at a 1 month interval. The drawback of this is that these are very painful, and that the and systemic
So
side effects could.
what can you do to obviate the pain?
So we can so basically the solid central part of the lesion is very painful, so you prevent injecting directly there, and
No.
you can
No. Even before like injecting, what should you do? Will you directly inject the steroid or you mix it with something? So you generally mix it with local anesthetic.
Okay.
So that will
Definitely.
prevent the
Hey,
pain.
Yes, sir. And sorry, go ahead, sir.
Yeah, and there is something called as silicone sheets as well. Silicone sheets, silicone gel
gel.
to
Yes, sir.
minimize the scarring.
So that was like I was going to like gel sheeting, like silicone and
Yeah,
non-silicone sheets both. They basically stabilize and moisturize the scar and decrease inflammation, sir.
So
And
when do
you
you
can
apply
also
them? When do you apply them? And how frequently do you apply them?
so you they are generally basically they are reusable material till the adhesive material disappears, sir. So you can actually the gel sheets can be removed and cleaned daily till at least for 4 to 5 uses, sir. And
So you have to apply them once you are, once the, sutures, if at all they are sutures, you remove the sutures, or if they are clips, you remove the clips. So usually 7 days after the wound, after surgery, you apply the silicone sheets, and I think that is, and then you repeat it for a period of up to 3 months, especially in people who have tendency to form hypertrophic scars or keloids. It can also be,
yes,
used if, for example, if you have revised a keloid or a hypertrophic scar, as soon as the wound is, you're happy that the wound is healing, you can start applying the silicone sheets, either silicone gel or
yes,
silicone sheets.
yes, sir.
any other methods? You've written other methods.
So
Other, I think all of you should speak to, Aditya Patil, and, find out how he does the, treatment of keloids, and, what is the, see, I think you should show initiative. Go and speak to them, find out exactly how they deal with keloids, because they are the people who deal with it regularly. We can't keep on spoon feeding you. You have to show initiative. I think I expected one of you guys to have spoken to Dr. Aditya Patil today or yesterday. He has come. He came to the hospital today. You knew there was a class on wound healing. You should have spoken to him and come out with this information. But nothing. See, this is the kind of, initiative and enthusiasm you have to show to learn. Otherwise, you won't learn. Okay, Ainas, what are the other methods?
so that was
which
basic
is which is in vogue now.
so laser therapy, which
Yeah,
uses pulse dye lasers and the
there are
Nd:YAG
various types
lasers.
of lasers. Yeah,
Yes, sir.
so
And cryotherapy as well, sir.
correct.
These are the other methods, and one is there's an anti-allergic drug which is like it's called tranilast, which basically inhibits TGF beta 1. So this is also helping in reducing scar inflammation, but not a lot of studies are available on this drug as of now.
So laser therapy helps in keloids and this one and hypertrophic scars also.
Yes, sir.
Yes, sir.
What lasers do they use?
Commonly used are what? Ainas, you will tell.
So this there's one pulse dye laser, then the Nd:YAG
Nd:YAG. Yeah,
and
those are the two commonly
two
used.
common. Yes, sir. And carbon dioxide
Carbon
ablative laser.
dioxide, fractional ablative laser, NAFR laser. There are so many types, but commonly used are those two: Nd:YAG and pulse dye laser.
Continue, ma. Is that
Yes,
finished?
sir. Yes, sir. Like just the overview for how do you go about if there's an immature hypertrophic scar, then you'll try for sheeting methods or silicone gel. And if it is for more than 1 month, then you'll consider laser therapy. Linear hypertrophic scars, again, silicone gel for 2 months, and after which you try for intralesional corticosteroid injection. And if that is not functional, then you try for laser therapy and pressure therapy. And if there are severe scars, then you plan for surgical excision and post-operative sheeting methods, or surgical excision with the corticosteroids, and 5-fluorouracil can also be used. And if it's a widespread hypertrophic lesion, then which is mainly primarily caused because of burns, then first basically treating the parameters related to burn, and then after that silicol gel or sheeting and pressure garments can be used, and even laser therapy and a combination of laser, surgical, and the sheeting therapy, all of these to be used together. Then for the treatment of keloid, again, there's the conservative management, which involves the use of intralesional corticosteroids. Here, the dosage of triamcinolone is 5 to 10 mg, and then again you can you can use a tape or plaster available in the form of topical corticosteroids. Then there are also intralesional chemotherapeutic agents, which includes fluorouracil, which is effective in small or moderate size keloids. And there are bleomycin injections, which are also available, which can be administered, which will help in reducing the keloid. And finally, there's the surgical excision in case of large-sized keloids. Again, the treatment for minor keloids being silicone gel, sheeting, intralesional corticosteroids, followed by laser therapy. And also, the one important point is explaining to the patients about the recurrence rate. Surgical excision, which can be done with adjuvant silicone gel sheeting, radiotherapy, and alternative therapies, that is in using the chemotherapeutic agents. So there is acute wound management and chronic wound management as well, sir.
Yeah, how many slides more?
So there are a few more, sir. Like acute, chronic is small, sir, but acute wound management has this negative pressure therapy and hyperbaric oxygen chamber and all that, sir, in this.
Sir, should we carry on? It's already 10, or should we do it in another class?
Just 10 o'clock already. What is the next class you have, Einass?
So this was my class, sir, for the month, sir. Like after this, Nikita ma'am was going to do it on the tissue regeneration and
Yeah, I think you
yes,
can
sir.
do that before that,
Okay, yes, sir.
because there is no point rushing through these things.
Yes, sir.
And anyway, your attention span is only 40 minutes, so you already exceeded that. So, you can't keep on listening for too long.
Sir,
Yes, sir.
okay, then we will end the class. Before ending the class, comments. Sania, Nitya,
It's a very good class, and like you said, it should have been in some more depth. But I think even we should give a reading in depth, sir. Otherwise, it is a very good class, sir.
Nitya,
Uh, she did very well, sir. Yeah, we should have gone into the depths, sir, like about keloid and hypertrophic scar, consulting plastic surgeon also. So otherwise, it was a detailed class.
keloid hypertrophic scar, she actually mentioned all of it, but what is the current line? What do they do? You should
Practical.
have practical this thing.
Yes,
So
sir.
what I think keloid they do if it is extensive is they excise and immediately in the post-operative period they give radiotherapy.
Yeah, and then
Yes,
silicon sheets.
Yeah, silicone sheets. Yeah.
yes, sir.
So other than that, more depth was required for this pathophysiology and the factors causing delayed wound healing. Like all of you superficially mentioned the causes, but why it happens, all of you should be knowing rather than us telling you.
Yes, sir.
Ramkrishna sir, any other comments or suggestions, sir?
No, nothing, sir. She did well. The only thing we practically use these newer modalities are not available with us. I advise massaging the wound, that scar. That will really help in getting a better scar, sir. But the patient should diligently do it every day for about 6 months. If they keep on massaging, putting some coconut oil or Vaseline, something, that will give a good scar.
Sir, Ravishankar sir?
I think considering that Ainas had set a usually fairly good standard, her class was not as educative and in depth. I think all of you need to take lessons. See, I think you have to, whenever a topic like this comes up, go back to physiology textbooks, the physiology of wound healing, go back to pathology and the pathology of wound healing. I think that is how you have to study. You have to go a bit more wider in your in your reach, and also deeper in your knowledge. And that also, and in addition, you have to read the latest, what is the latest in terms of wound healing. And always, for example, if you are talking about management of breast cancer, go that that week or whatever, go to Dr. Swaroop, speak to him, find out what is current, what are the things, that kind of enthusiasm you have to show. If you 2 minutes or 5 minutes, I think they will be very happy to discuss with you. But I think that is that is what is lacking. See, you guys are good compared to many other postgraduates, but we want you to be better than that. We want you to be the best. So for that, you should show initiative, enthusiasm, which I found very lacking in this particular class. So I think you need to do better. It is not a criticism, it is a suggestion. Okay.
Yeah, I agree with Ravishankar sir. Ainas usually you do very well. Today, I think you have not gone into as much depth as was required for this kind of a topic. So other than that, presentation, everything is fine. Okay, so for next class, we will see how it goes. So I think we will conclude the session if there are no more
See,
questions or comments.
Niranjan, one
Yes,
see,
sir.
see what I want and what Niranjan wants is, when we finish this class, we should feel we have learned something. I think that is very important. See, I think I think Niranjan and I, Ramakrishna sir, we are all fairly well, informed. But at the end of this class, we should feel that we have learned something new. That is how you should prepare and present. That is my
And also one more thing is this is such an important topic. If you understand the pathophysiology, you people when you become independent consultant, you will know what kind of wounds, how should you should treat rather than blindly believing okay diabetes causes delayed wound healing. Why? If you know that it is neurological factor is there is some other issue is there, you will be trying to address those topics rather than blindly believing okay just control diabetes. You understood what I'm telling? So there the importance of knowing the things in depth comes into picture, and you will never forget all these things if you understand it rather than just mugging it up like local systemic factors. There are 5 factors there and 5 factors here, but that will not help in any which way. You will just theory you will know, but practically if you don't know, then you won't be able to apply that in your day-to-day practice. Sir.
Okay, I think,
Yeah,
yeah, I
we
think
will, I think,
hopefully the
conclude.
message is clear. Yeah, good night, all of you.
Yeah, good night, sir.